We move on to the next talk, which is by Professor ARUN JAIN, and this is dealing with the corneal tomography with regard to the Pentacam AXL. Professor JAIN, please.
Thank you, Amit, for giving the opportunity and putting together this nice instruction course on diagnostics. So, I'll be talking about elevation-based tomography with Pentacam AXL. There are a lot of indications, or there are a lot of problems where the Pentacam can be used, but I will be mainly restricting myself to the corneal problems and calculation of IOL power in post-refractive surgery. I have no financial interest in the subject matter of this talk. And as we all know, there are a lot of instruments available which can give us corneal topography. Many of them are slit scanning and elevation based tomography. We have rotating Scheimpflug principle, and in that we have again a series of instruments, but I'll be giving my talk based on Pentacam only. And these are the various conditions for which Pentacam has been being used. Most common is screening for refractive surgery to rule out keratoconus or ectasia or progression of keratoconus, especially subclinical keratoconus, and also it has applications in planning phakic IOLs and intracorneal rings, and in cataract surgery, lens densitometry for knowing the hardness of the cataract, as well as post-refractive surgery IOL power calculations and choice of IOL, which type of aspheric or toric IOL we can choose based on the Pentacam findings. So there are a lot of applications even in glaucoma. So I will be restricting myself only to these three: screening for refractive surgery and post-refractive IOL calculation and choice of aspheric IOL. So coming to the first topic of keratoconus screening. So there are various maps on this Pentacam. On an anterior elevation map, you have to look for any elevation more than 12 micron is considered significant. Any value more than less than 12 micron is considered normal, but more than 15 micron in central 5 millimeter area in the best fit toric left side map are typically indicative of keratoconus. Similar number which are about 5 micron more on the posterior surface are taken as significant. These values are significant only if present in central or paracentral area in a localized pattern. High plus value may be seen in periphery because of astigmatism, and they do not denote abnormality. So abnormal elevation is present can be present in an R-line pattern on the anterior as well as posterior surface. So this is the anterior surface, and this is elevation front. This is the sagittal map. So they can be present on anterior as well as posterior surface, and it can also be in the form of tongue-shaped projection rather than, because as the keratoconus progresses, this island separates and it becomes an island, and this is again in the form of island. And this is the representative patient who had a -2 diopter spherical refractive error, and they came for LASIK surgery. Pachymetry is 560 micron, which is within normal limit. There is little asymmetrical bow tie on sagittal map, but you can see the elevation on back side is to the tune of 20 micron, which is significant. And this is the other eye of the same patient, where you can see this is the left eye and this is the right eye. There is an anterior map, sagittal map shows a K reading of 58, and there is an elevation, front elevation of plus 36 micron, and posterior elevation is much more, so more than 20. So this is a overt case of keratoconus. But sometimes when the findings are subtle, we have to look at the Berlin embryosa enhanced ectasia display and the comprehensive pachymetric progression. So this is an example just to show that this is a patient who had a 460 around micron thin corneas, and what in this Berlin embryosa map does is a 3.5 millimeter optic zone centered on the thinnest point in the is excluded from the reference shape map. So you get a reference map like this, and creating a new reference surface has minimal effect on the normal cornea, but it greatly enhances the ectatic cornea or irregular cornea. So if you see here, these values are on anterior and posterior surface elevation, and this is on Berlin embryosa map. So it enhances the elevation both on anterior and posterior surface. So this is called Berlin embryosa display map, and this is very sensitive screening tool for keratoconus suspect or firm frost keratoconus, and also patients who come for refractive surgery. And so this is another patient which has what to look for on this enhanced Berlin embryosa map. So you have these value also. These are the elevation. These are these 5 values are when they are in white, they are within 1.6 standard deviation. When they are displayed in yellow, they are more than 1.6 standard deviation, and red means they are significant more than 2.6 standard deviation. And the overall D value, which is more important than the individual value, if it displays in red, and even if these elevations are not there, then one should not proceed on to do a surgery. And there are 9 important parameters on this map we should be looking for. 5 of these are these values, which is DT is anterior elevation change, DB is posterior elevation change, this one, and DP is pachymetric progression, DT is thinnest point pachymetry, and DY is displacement of thinnest point from the apex. And here you get a artmax. The cutoff value is 339 micron, and other values of anterior and posterior elevation and Kmax. These are the important things to be looked for in the Berlin embryosa map, and in this case the overall D value is around 11.48, which is significant, and the pachymetric progression index is normally is around 0.12, but here it's 0.64, and artmax is 1.26, which is less than the normal one. So this is a overt case of keratoconus. And this is another map, holiday report map, which is a best fit toric ellipsoid map. And if in this map, this is tangential map, anterior surface, this is pachymetry, and this is elevation map on the back surface. If the hot spot on tangential curvature, this is the hot spot, elevation, and the relative pachymetry, thinness pachymetry, as well as posterior elevation, if these 3 points coincide, then it is diagnostic for keratoconus. So this is more important than overt keratoconus, because many of the cases which come for refractive surgery, they may have subclinical keratoconus, which is defined as a state, a premature form of disease in which characteristic keratometric, retinoscopic or slit lamp findings of keratoconus are absent, but there are only mild topographic changes which are consistent with clinical keratoconus, and they have a potential to develop ectasia after the surgery if we are not careful about diagnosing. This is a representative case which has a very high K rating, more than 47, and you can, as you can see, the Pentacam itself says it is abnormal, this is not within the normal range, and even the one of the indices is shown in red, and you can see the pachymetry is thinner, but there is no asymmetrical bow tie, there is no elevation on anterior and posterior map. pachymetric progression is normal, but once you go to a bad map, the pachymetric progression is in yellow area, so one has to be careful, as well as the D value is also more than 1.6 standard deviation. So you should wait and watch and take a family history. If the patient has a family history of keratoconus, you should avoid doing surgery in these cases. This is the other eye of the same patient. Here you can see the pachymetric progression is in red, and D value is 2.18. So you should avoid doing refractive surgery in these cases. Coming to IOL power calculation in post refractive surgery patients, if you don't have a Pentacam, you don't have to worry. You can go online. There is ACRS website as well as APACRS, where you can have all these online calculators. But you can also have the tomography. This Pentacam gives us equivalent K reading, which is based on true measurement of anterior and posterior corneal surfaces, and based on the true refractive index of cornea, which is 1.376, and based on this we get this EKR map, and the EKR value in the central 2 to 4 millimeter of cornea, they are normal, but Savani et al. Has shown that we should be using 1 to 2 millimeter reading of EKR rather than 4.5 millimeter. They are more accurate in calculating the IOL power. This is a patient with post-radial keratotomy with the diminished vision, and 8 RK scars were there. So patient wanted surgery, and this is the biometry of the eye, and these are SIMK reading, and but the EKR readings are around 34.7, on an average around 35 at 1, 2, 3, 4 millimeter. And this is the Pentacam holiday report of this patient, and you can see the EKR value, and taking into account the EKR value and calculating the IOL power using the SIMK, we could have chosen this lens, okay, because on SIMKs were higher, but EKR values are lesser because there is a fallacy in calculation of SIMK. So targeting a myopia of this, we used a lens of 19 diopter in this case, and we ended up a postoperative reduction of 1.5 cell. But if we had chosen a lesser power, we would have ended hyperopic in this case. And then using this Pentacam for choosing neutralizing spherical aberration in cornea. As we all know, as the age advances, the negative spherical aberration of the crystalline lens also become positive, and it adds to the corneal aberration. And we should be using, depending upon the status of the patient, if a patient has undergone hyperopic LASIK, they have increased positive spherical aberration, so we should have we should be using either a traditional IOL or wavefront with positive spherical aberration. Post-myopic surgery, the negative asphericity, positive asphericity increases, so we should be using negatively aspheric IOL, and where the any chance of subluxation or decentration, we should be using aspheric neutral lenses. This is a cataract surgery planning map. In this map, if you look here, this gives us the total spherical aberration at 6 millimeter zone. So normal is around 0.27 micron. So depending upon that, one can choose a spherical IOL, and different IOL have different magnitude of asphericity. And as you can see, these are the two eye of same patient. In one eye there is a normal IOL, but in other eye there is a negative aspheric. You can see the scleral ratio is close to 1, and the point spread function is also very good. So Pentacam helps us to in choosing different types of aspheric IOL or non-aspheric IOL depending upon the asphericity of the cornea. And here you can see again in one eye there is a normal lens, 80 lens, in other eye IQ. You can see the point spread function also very good in this case. So so these are also called wavefront corrected IOLs. So I think that's the that's the end of the talk. There was okay. I think I should stop here. So I have covered. Yes. Thank you.
Well, thank you, sir, for an excellent talk on Pentacam and what it can do for us. Any questions from the audience? We can take one question from the audience, or any comments from the panel. So when you're planning a toric intraocular lens cataract surgery, do you think that Pentacam, looking at it, is a must, or
So
you just rely on sometimes on biometry, like it tells you?
yeah. So once we are doing a toric intraocular lens, first of all we have to be sure that the axis and the magnitude of the toricity. So we should sort of confirm that on at least two instruments. One is the IOL master, and then you have the choice of either a Pentacam or any other instrument. But the advantage of Pentacam is it gives us also the posterior corneal astigmatism. The IOL master 700 also gives us a combination of total K. So total K is very important because posterior corneal astigmatism also accounts for the toricity or the refractive astigmatism. Though there are in Barrett's toric, it's presumed, but the actual amount of toricity, because the rule is, if it is with the rule astigmatism, we undercorrect it, and against the rule astigmatism, we overcorrect it, because the toricity on the posterior surface is like that. But Pentacam will tell you exactly this amount of posterior toricity. So it is more accurate as compared to other devices which doesn't measure the posterior corneal astigmatism.